Hi, everyone, and thank you for joining us for another RNS Facebook. I'll start in a second, but first, you know how this goes. Share us, like us, love us, all that good stuff, and shout out to us. Let us know you're there. Send your questions in. We're more than happy to answer them. And we have, the obstetrician on with us today. So any of those questions, get them in. So I start. We usually do around the neighborhood.
Can you hear me? I'm having signal problems.
I think we might have lost Kathy.
Ah.
Okay, so while we try to find Kathy,
Okay.
what we usually do is go around and tell you all what is happening in our state. So I'm Barbara Kinsell, and I'm a pediatric nurse at the Children's Hospital of Georgia. And so in Georgia, as of this afternoon, we have 3,441 new cases. So, we're not doing so well here as of late. Those are new cases as of today, 13 deaths in the last 24 hours, and 244 hospitalizations. If they don't break that down into how many of those are ICU or just on the floor. So we've had our numbers going up, and we're still pressing forward with keeping things open. And school is our hot topic because the first school districts are set to open on August 5th. So I have been fielding school calls for the last 2 weeks. So that's what's going on in Georgia. So let's see what April has to say.
Good evening. My name is April Johnson. I am an adult rheumatology nurse practitioner. I work in Oklahoma City, Oklahoma for the McBride Orthopedic Hospital. And here in Oklahoma, I'm sure we're on the news right now because our governor tested positive for COVID-19. So this is the first governor has tested positive. And as you guys know, we have been very supportive of not wearing masks and just kind of opening up very quickly. But I believe that is going to change now because as of today, we have about 22,814 confirmed cases. Yesterday, we had over 1,000 new cases. Today was not as many. We had 332 new cases. We've had a total of 76 deaths in the Oklahoma County, but a total of 432 deaths total. But again, this is quite a few more patients compared to where we were just a month ago. I had the privilege of speaking to one of my patients who sits on the board for one of the big school districts here in Oklahoma. And our schools are supposed to open up in 4 weeks. And she is extremely concerned about opening the schools and is encouraging more healthcare providers to reach out to our superintendent and to email and just express our concerns about us not being fully prepared because some of the schools are still very resistant to wearing masks. And we're just divided. We're divided and we're just not on the same page. Also, it looks as though there's talk of closing bars down again and restaurants down. So we're kind of going back backwards. We're not moving forward. So I'm just hoping that we can get some good news in the next few weeks.
All right.
Right.
Good. All right.
Here's Kathy. Okay, I hear Kathy now. There you are. Okay.
Okay. Sorry, I had some technical issues that I have to work out on my end here. But thanks for picking up there, Barb. So Michigan, we're actually doing pretty good. I don't have the statistics in front of me right this second. That's actually how I lost my connection, was trying to grab those really quick because I forgot. But we're actually doing pretty good. We're in phase 4 right now. And as long as we stay in phase 4, we're probably moving towards opening our schools in the fall. That's like the hot question when everybody comes into clinic. You know, what do you think? You know, we have to decide to do online schooling or in-person schooling. And I don't know what to do. And, you know, what about the immunosuppression my child is on? What is their risk? And, you know, the questions are just endless. And so, you know, it's hard to say because you can't get how can you give advice when you don't even really know, because we don't know enough about this. And so, you know, you talk about having enough PPE for all the healthcare providers. How can we possibly have enough PPE in this country for schools? I don't even see how that could be possible. You know, not even PPEs, but disinfectant. I mean, I can't even go to the store and find a can of Lysol. How are we going to have enough cleaning products for the schools? But, you know, I think it would be great for the kids to go back. I really do. I think they really need it. They need to see their friends. They need to be together. They need to see their teacher. You know, I think the teachers are going to have the best interest, you know, for the kids, because they love these children. You know, they treat these kids like they're their own kids a lot of times when they're in their care, and they have a very special relationship, and the kids love their teachers. So even if they can only go to school in the beginning until flu season hits, I think it would be a really super good thing for them. I think it would be very important. I think the social isolation for us adults is very hard, but I think it's even harder for the children. You know, I mean, I get out to go to work, you know, well, you know, kind of whoopee, but, you know, at least I get out. The kids aren't even really getting out, you know, to do much of anything. So anyways, that's just my 2 cents in it all. But tonight we have a very special guest, Dr. Renee Page, and she is from Augusta, Georgia, and she used to be a Detroiter for quite some time, and now she's in the South. So now you're kind of in the thick of it, Renee. So Dr. Page, tell us a little bit about your thoughts on COVID, and, you know, let's start from the beginning when all this first started happening, because it was like one day life was normal and the next day everything was just, you know, thrown up in the air at us. So how did this all, you know, come down for you?
So we started to become aware, as Barbara can tell you, because we started seeing a slight increase in numbers. And we have an advantage in Augusta that if anything's going to happen, it's going to happen in Atlanta first, because Atlanta's right, exactly, right. Because Atlanta is such an international city, right? It's the busiest airport, I think, in the world. And so we started kind of hearing, oh my goodness, cases seem like they're coming up. And an unfortunate early hotspot before things kind of started coming into the news with New York and Connecticut and that area was in Albany, Georgia. And one of my other jobs, which I'm sure you ladies and gentlemen can relate to, is to look over the curriculum for my medical students. So we have a campus down there in Albany, and they, you know, a lot of our healthcare providers, nurses, doctors, nurse practitioners have tons of connections to us in Augusta, not just the formal connection. And so they were hit really hard. One of our ladies who works with one of my coworkers in another part of my job, lost 11 family members to the Albany. I know. So it really started hitting us that this is not just, not that it matters. We are caring people. So we realized that if something happens to anyone, anyone's life is needlessly, sacrificed, that it is a very, very big deal. But that hit us extraordinarily hard. So my department on the OB side said, we got to start preparing for mass, not really casualty, but that's the best analogy for mass coverage. If we have to kind of pull the people that can work more, we'll do that. We had, I think at that time, 2 pregnant residents. Many of you know that OB, about probably 5-7 years ago, was 82% female. I think it's probably more like 90% female trainees. So I have 20, we have 20 residents. I feel like they're mine. They're not technically mine. We have 20 residents, and 2 of our ladies were pregnant. So they got pulled into outpatient rotations, which may or may not have been the safest decision, but we were doing the best that we could at that time. So this was basically March when AAMC started saying, what are we going to do with trainees? When lots of hospitals across the country started looking at putting hold on elective surgery. So through that period, through pulling our medical students, controlling very carefully what our residents did, we never had to pull everyone home, meaning we never had to go to like day, night shift continuously, but we really had to be very careful. And if anyone in our kind of tiny stratosphere of OBGYN, specifically labor and delivery, developed symptoms, we were sending them home. At that time, our hospital, which I think really did a really good job, at that time, our hospital was also trying to secure PPE for us. So we did not initially have N95s, but we also weren't 100% sure that we needed them beyond when a patient was being intubated or when we were doing actual surgical procedures. But we didn't have them. So we were just trying to do the best we could with double surgical masks or things like that. So fast forward to, it's, 2 weeks, 4 weeks at a time, we were able to obtain PPE. As soon as we got N95s, I started wearing them and encouraged my colleagues to do the same for vaginal deliveries. It's not an aerosolizing procedure as far as we know, so the risk shouldn't be so great, and the exposure is pretty short, a couple of hours. Of course, people feel like they're pushing for a lot longer, but it tends to be around a couple of hours. And so we started wearing those N95s, started, engaging with patients. At this point, here, mid-July, where we have been through all of the imagined and unimaginables. We do have a few patients that we're taking care of who were COVID positive. We have a tiny itty bitty unit that's, we put gowns on to go in, we put our N95s on. Each person has each provider, so all nurses, all physicians, all residents, even guests. We don't let students get exposed to any patients who have N95s or who have COVID positive because they're not essential to their care. But everyone has an N95, and we have a few backups. So we send it down to be treated. As many of you know, we have a process so that we can reuse N95s, which we had to do all across the country to make the PPE last for us. So we are now using N95s for C-sections, for any patients that are COVID positive, unknown, or persons under investigation. And other than that, and really, really limiting the amount of people that come into our units. We are almost business as usual. On the outpatient side, we did make changes as well. So we canceled elective cases for about a month, and I think we should have done it longer, given the fact that our numbers are going back up. Right. So I think had we kept those elective cases out for 3 months, we might be in a slightly better situation. Although I will say that the process by which patients come through to the hospital is very different. You can't just come in from multiple entrances, and you can't have for a short time, we were having patients come in and get dropped off and have surgery. So imagine you're having your hysterectomy and nobody's there with you the whole time. So you're dropped off, somebody gets a phone call and you're discharged, and somebody has to come pick you up at the front door. So that is better. But the process has changed because we have better testing. I have to say good things about Medical College of Georgia. We developed an on-campus test for COVID. So we have the advantage of having very rapid testing. We just need reagents. So if anybody's got any reagents out there, just send them on down.
Send them down.
We could use them. But so all of our patients are tested. They're scheduled. They have scheduled tests before they have an induction of labor, before they have a C-section, or any scheduled elective procedure. So that is actually helping us quite a bit. The tough thing, as I'm sure all of us have experienced, is the asymptomatic carriers, of which there are probably millions, and the people who come in with what we think is an atypical presentation for COVID, because we just don't know. We're still figuring out what to do. So I'm sure somebody has some questions, but let me tell you about the outpatient side. So OB never closes. We can't just shut the door and say, you just handle this little, pregnancy thing at home and call me if you need me, but don't call me. So we really said, in our outpatient clinic, we're not going to close, but we're going to try to social distance as much as possible. This is before we were routinely wearing masks in clinic, because we didn't have them and we were still figuring out how bad it was in Augusta. And so we saw OB patients. I would do telephone visits. Some of my colleagues are doing a lot more telehealth, but I would do telephone visits for people that just had to talk to me. And it was really a good experience. Now we're kind of back, but my husband's an OB as well. And he and I were just talking about the fact that we need to go back to the social distancing and, non-essential visits for gynecology. Of course, OB patients need to come and see us, but non-essential visits for gynecology, just because the numbers are higher than what our previous peak was.
Right. Yeah, geez, it's so funny hearing all these different perspectives. We've had, ID on here and, some different specialties, and it's so interesting to hear how everything evolved is, that night the world turned upside down.
That's exactly right.
Hey, Heidi out there. I'm so glad you could be on. Missing you out in California, that nice warm sunshine. It's a little rainy here in Detroit. And hi to Wanda in South Carolina. I hope you're staying well there, Wanda. And thanks for joining us tonight. Let's see. Where do we even begin?
We can begin with pregnant women who are worried. If they have a COVID positive test, would that be a good thing to?
That's a great place to start.
Yeah. So what happens?
So if I have a pregnant woman with a positive COVID test and she has other children, especially small children. I'm going to ask her to isolate as much as possible. For many of us, all of us, for the most part, right? I'm sure everybody on this call, we love our children very, very much, and we never want to be away from them. But if someone can care for your children for that short period of time, the 10 or 14 days that you're, thought to be shedding the most amount of virus, that's what I would advise her to do. Regarding the pregnancy, we don't have any treatment. So it's not like we have an IVIG that we just pop off the shelf, which costs several $1,000s. That's a little room joke for you. But, it's not like we can pop that off the shelf and say, hey, just take this and you'll be good. I look at what's right in front of her in the first place. And if she doesn't have another caregiver that can help her with the children, then I recommend that she wears an N95 as much as possible, which feels crazy, right? Wear an N95 at home so you don't infect your other children, and try to wash all the time and things like that. Regarding the fetus, as I was preparing to participate in this panel, sorry you had to chase me. It's not your job to try to chase me, so I apologize. But as I was preparing for this discussion, I came across a case report that many of you are probably aware of a supposed transplacental transmission of COVID. So here's the problem. The way this virus acts, it is, number one, we would have tons and tons of people who had babies who were infected and sick if we had specific targeted transplacental transmission of COVID, like we did and still do with Zika and CMV. So if you get infected at the right time during your pregnancy with CMV, your baby will have significant specific birth defects. That's not the case with COVID. So the case report, and I want to say it was there was an article in the New York Times, but I want to say it was in Nature something, a version of Nature, not the original Nature journal. And the report was that mom was infected, baby was tested, plus there was SARS, CoV-2 on the placenta, and they're just pretty sure this was transplacental transmission. But baby was almost asymptomatic and then was fine. Like 3 months later, everybody was fine. That is not the way newborns act. And I'm not a pediatrician, but I know newborns are born not with, the strongest immune system. Let's just tell the truth. So if there were any significant infection, I think the baby would have been affected. So that's one part about that case report. And number two, of course, it's a case report. So, we just have to put it in perspective. It shouldn't be something that changes our management, including like telling mom, your baby's going to have birth defects or anything like that. We don't have any clear evidence that shows that. In fact, as I was just sharing with Kathy, there is a paper that talks about ACE receptors and other receptors that says that the transplacental transmission, really shouldn't exist with COVID at all, but it's certainly not as significant as it is, as I said before, targeted with Zika and with CMV. So I would do a lot of reassurance, which is part of my job, as it is for you. I spend a lot of time reassuring, of course, brand new moms, and this is especially hard for all of us. We're all a little bit anxious about COVID, and imagine bringing a little tiny baby into the world and feeling like, who is going to be there with me? Am I going to be isolated? What if my baby, does test positive? And so I provide a lot of reassurance for moms who say, you know, if I test positive, what do I do? And then just treat her very, you know, test babies right away when baby's born, and watch them closely for symptoms.
Yeah, I mean, it's really hard being a new mom, you know, and I can't even imagine this day and age with COVID and being a new mom, because it's just changed so much. You know,
It has.
I mean, it's changed who can be in the room with you. I mean, it's changed everything from the beginning, right?
Exactly.
You know,
from the beginning,
all your prenatal visits have, you know, are different,
changed.
I'm sure.
Yep. We're trying to do fewer ultrasounds because what we're trying to do is distance people as much as possible, right? So it's changed what we can do for care. But we also don't want people not being scared to come to the hospital. We don't want people delivering at home. There was a recent celebrity, actually, you know, in Florida, who decided to deliver at homes partially, supposedly, because of COVID. And the baby didn't make it. I think it was an 11-pounder or something like that. And that's not the direction we need to go in. Hospitals are some of the safest places for people to be in. We are just trying to be as absolutely careful as we possibly can be. So what does that mean? It means limiting the amount of people who come to the hospital, even though we're testing mom and her support person, because we're not saying, you know, dad, because she might choose her mom to be there. She might choose her mother-in-law, you know, you just don't know. So her support person is with her, and you have one support person at our hospital the whole time that you're there. And that person can come and go, but we try to limit that travel as much as possible. If baby goes to, obviously, you know, term baby that's born and can stay in room, that's the ideal situation because mom and baby are never separated. If baby has to go to NICU, then unfortunately only one parent, usually mom, can go and visit baby because mom needs to go up if she's breastfeeding or something like that, and, you know, visit with baby and that kind of thing. So it has changed. You're absolutely right, Kathy. It's changed everything that we do, everything we think about. It's changed how often we touch our faces, right? It's changed especially because I know you changed a lot of your the way you do things every day in Michigan because you had a great response there. But I don't know about you, but when I'm going home, I'm thinking, okay, I don't want to make an extra trip on the way home because I don't want to potentially expose my kids to anything. So I'm trying to make as few trips as possible, even though I go out every day. So it's changed everything. Our whole world is upside down.
Yeah.
Dr. Page, I'm curious to know how many moms, pregnant moms, are you seeing test positive? And then is there a protocol to automatically test the babies after they're born for COVID? And or have you seen positive babies tested?
I have very, very, very few patients who have tested positive. Everybody's tested when they come in. So all of my patients over the last, I want to say 2 months, but I have to remember what month we're in. So probably mid-May, so probably 2 months, has been tested when they come in. And then of course because we need to isolate, so we act on that test. I do not know if they're testing babies. I can't answer that. I don't think so if mom is negative. Now, you could argue whether that's really appropriate because of the amount of false negatives we have. But the other piece that I didn't address is that we're also trying to discharge people as quickly as we possibly can. So if you have a vaginal delivery, when we would keep you for 2 days sometimes. If you're looking good and baby's looking great, everybody's cleared, you can go out in just about 24 hours. And that has been mostly a good thing. As long as there's close follow-up, I'm very, very comfortable with that. I know, and Barb may be able to tell you a little bit more, but my understanding on the children's side is that we have just started to see positives over there. That's what I hear from my pediatric colleagues, but there haven't been a ton. It's just that it's like crazy presentations, asymptomatic, of course. I know of a kid who presented just, with a GI before we knew that GI was a thing. We thought it was just a GI thing on the adult side. So, but you're absolutely right. I personally wouldn't want my baby to be put through that test, especially if I test negative. So maybe that sounds a little bit selfish and maybe it's not correct, but obviously if babies show symptoms, they get tested.
Right.
So we've seen crazy things in the Children's Hospital. I think maybe one straightforward case of COVID where the child was there for maybe 48 hours. The rest of the ones that are kind of just now trickling in, I'd say within the last 2.5 weeks, have been the crazy things. I mean, we're starting just to call them the COVID Kawasaki Misty. We don't really know what it is. The majority of them have convincing symptoms, and so far only one has had a positive COVID test, but I mean, we had 2 or 3 right in a row that had definite Kawasaki symptoms. And they were COVID negative. So we're seeing crazy things. And so thankfully, no one has been sick enough to need the PICU right now. And so far, they're all home except for the new crazy COVID Kawasaki that we hear just got admitted this afternoon. So not really sure what that one is about. So we're not seeing anything straightforward. And we haven't seen any infants that I know of to say that, maybe there was a baby that went home and then came back a couple of weeks later. We haven't. These are all, 1-year-olds on up. So, because we just don't know, and we're not seeing straightforward anything.
So go ahead.
More kids.
I didn't. Did you get the question or the comment? Because I didn't hear her.
No, I didn't hear her either.
Sorry, I'm breaking up. Sounds like you guys are, you love my technical issues, right? Oh my goodness.
It really makes me feel good, Kathy. You have no idea.
It's my internet connection. It's making me crazy. And my husband is just figuring out that it's a problem. And I've been telling him for a couple months now, it's a problem. So now that it's a problem for him, it'll be getting fixed, I bet. Anyways, it sounds like you guys in Augusta are a little behind us here in Detroit, because we've been seeing the Kawasaki, like the atypical presentation. We've been seeing the MIS-C for a while. So we have a decent number of kids that test positive. We've had a couple of our rheumatology patients test positive. I've had some kids on biologics that have tested positive, and they've done just fine. They talk about how sick their parents were, but they weren't bad at all.
Yeah.
So I guess that's a good thing. But we have had kids that have been perfectly healthy and have ended up in the PICU and, ECMO and stuff like that. So, I mean, it's very real.
It is.
So you guys are a little behind us as far as that goes. So you guys may start seeing more.
I hope not.
I hope not. We're happy being on the, kind of the low end. We've had several kids tested either because they had some strange symptoms or somebody in their family. And I will say, and I'll knock on whatever kind of wood is around me, that so far, none of our rheumatology kids have tested, of the ones that have been tested, have tested positive. So, and we had a couple that we, would have just bet on that would have come back positive, but they haven't. So we've been very, very lucky, very blessed with things so far.
Yeah,
I will
we've
say
definitely
since
had a lot of kids that have come back negative, and that we're thoroughly convinced they're false negatives.
Right.
Many,
Yeah.
more than people would imagine.
Yeah.
Yeah, I agree, Kathy. You know, I treat adults, but I have unfortunately had multiple patients testing positive since the last town hall meeting that I had with you guys. I've had one of my patients just got out of the hospital, is on oxygen now. I have one that's still there. I have had several that traveled and went to different parts of the country, come back and tested. I mean, I've had at least 10 patients test positive just in a matter of a couple of weeks.
Oh my gosh.
It's scary.
That's very scary.
That's pretty scary. So, so let's talk a little bit about treatment for COVID, Renee. So, you know, we're using a lot of the steroids and the remdesivir. So what are the implications for a pregnant woman, you know, like prior to delivery? What are some of the implications of those medications?
So, you know, the latest data, when we kind of thought, oh, pregnancy definitely isn't a thing. And I can't remember whether the data came out of China or kind of that early European data regarding COVID, has been more information that we know about says that there are more pregnant women who end up in ICU if they're, you know, affected COVID. The ones that we have had, and I mean like a handful, have all been healthy and stayed healthy and didn't need to go into ICU. But the overall risk is relatively low. The concern is if you have any of the factors that all of us know by now, unfortunately, right? You have any comorbid conditions, you're obese. Strangely, it seems like non-Hispanic Asians in that particular study did a little bit worse as far as ICU admissions, but still mortality was relatively low. For steroids, the guiding principle regarding pregnancy is we treat it just like everything, as we treat pregnant women just like everybody else. So we always look at mom's ABCs before any worrying about the baby, including a term baby. Because if mom can't breathe and if mom is hypoxic, baby will be. You know, we kind of, if she's viable or certainly like mid to late third trimester, we're going to lean her on one side, preferably kind of put a little, thing under her, or under her right side so she can be tilted left. That gives more blood flow to baby. And I don't know of any negative side effect remdesivir would have, but steroids are a nothing burger. We just give it like water. We do, just like you do. You know what I mean? Because it's maybe there is a positive effect, especially if we have a premature gestational age baby. Maybe we can accelerate fetal lung maturity if we're, you know, between basically 24 to 34 weeks and do everything that we need to do for mom.
Well, that's promising, right? To all the moms out there that might be listening, you know.
It's scary.
It's very scary when you start talking about these drugs and when these drugs hurt my baby and, you know, all of these sorts of things. So what about when we're talking about the vaso-occlusive problems that happen towards the end of the infection and in the post-infection phase? What are your thoughts on that with the obstetrics and post-delivery?
So I wouldn't change my guidelines. There are, you know, kind of purely anecdotal, not even case reports that I'm aware of that are talking about increased stillborns and small babies that could possibly be associated with COVID, but I have not seen anything that I consider true evidence-based medicine. So I can, really hang my hat on that. I'm not going to anticoagulate a pregnant lady. I'm going to use my same, immediately postpartum lady, I'm going to use my same guidelines. We're doing a lot better than we did when I was in training, which is we're paying attention to what we should have been paying attention to, which is if you're immediately postpartum, you're actually at an incredibly high risk of developing a blood clot. And if you're COVID positive, it's in my view, an additional risk. So if you're obese, if you have, C-section, those kind of things, I'd probably at least consider prophylactic anticoagulant for a short period of time. And if she's breastfeeding, something safe for breastfeeding.
Okay. Do you have the hematology team on your speed dial too?
Not so much. Our hemonc is great, but they're much more comfortable with pregnancy than some of the other units in the hospital. But not so much, probably because we haven't seen as much, you know what I mean? To Barb's point, mm-hmm. we really have been lucky if we, in the first phase, when we were seeing positive patients in our hospital, those actually happened to be transfers to our hospital from other, hospitals who were in the overflow. Luckily, our Palm Crit people who aren't afraid of anything, how they are extremely well trained. And so they really were not doing, too aggressive fluid replacement, they were doing aggressive oxygenation and things like that. So and steroids, of course. So we were pretty fortunate for our sick ladies.
Wow, that's really good to hear. I think it's been in the news a lot lately about the high mortality rate of women, pregnant women. Mm-hmm. Can you speak? I know we're supposed to be talking COVID tonight, but I can't have you on here and not ask that question.
That's
right?
Fine.
So can you just speak to that a little bit?
Sure. So regarding pregnancy in and of itself, it's the view of pregnancy, and this is a societal view that I don't think I could easily refute, but the view of pregnancy is that it's definitely something that you're going to survive, and that you're going to come out with a perfect, 8-pound bouncing baby, boy or girl, right? This is something that we have been combating for some time because pregnancy is a really big deal. It is a marathon for your body physiologically. If you have any underlying condition that we don't know about, then even if we diagnose it during pregnancy, it can still be quite difficult to treat. So people do die, and it is horrible. It's horrible for all of us. I'm just going to say a moment that for those of us who've had patients who have passed away, we take it, not obviously as hard as the family, but we really feel terrible about it. When you have a very low mortality rate in your specialty like we do in OBGYN, and I'm not going to say that we're used to babies dying, because we hate losing babies and we hate losing moms, but it's just so rare that some obstetricians go once or twice in their lives that they see a mom pass away, or they have to code a mom or anything like that. People who are, work at higher volume places probably see it a little bit more, but it's nothing like other fields like onc, as an example, where, it's something that you happen to see all the time. So I think we have a multifaceted problem. I think part of our problem is that we, even as obstetricians, and we know better, we assume that the person in front of us is as healthy as they say they are. And so we have to just be a little bit critical when we hear something that sounds not quite right. The other half of it, especially with African American women, is that we all have bias, and we really, I know what my bias is, and I'll tell you in a second, but we really have to check our bias at the door and look at the patient, as all of us do on this call, I'm sure, as a member of our family who deserves the same level of care as everybody else does. When I read the story in, it was like one of the magazines, about Serena Williams saying, I feel like I felt when I got sick with my PE, and having to demand care so that she didn't die. I mean, she, according to her, almost died at, I think, like Cedar Sinai or some, wherever she was. And I saw her symptoms, and I, being a person who likes celebrities, was like, but she had a PE, like, who's not paying attention to this? This is crazy. But maybe this person, and I'm not making excuses for the person, but maybe the person like saw Serena Williams athlete, she's like probably in the best, in better shape than, most people on the planet, and didn't really think, didn't she have a PE before? Maybe she needs to be heparinized, like seriously, really, really seriously. She could die. So my bias is that I really have, I have a lot of people that I care for who are incredibly morbidly obese, and it is such a challenge. So I have to check that bias for me at the door. And that's unfortunately the problem with a lot of doctors. So I kind of have to, have a little chat with myself. You got to, this is just a regular person. This is not something that you can help or control, and you're not on like, a television show. This is real life. So I really, or I'm going to tell you honestly, I have people that are very difficult and are challenging of every background that you can think of. And those people are really tough for me to take care of. So any person, and I'm not talking about somebody who challenges me. I actually like that. I'm just saying people who I just feel like aren't taking care of themselves. And maybe that's where my, super morbidly obese, like my BMIs of 70s and 80s, I think that's where my bias comes for those young ladies. But it can be really, really tough for us to realize that we have bias, and that our responsibility is to take care of our patients no matter what, no matter whether we would live the same life. That's not what God put us on the earth for. I'm not talking about God. That's not related to COVID or anything like that. But I'm just saying that that's not our intent. Our intent is to take care of our patients no matter what situation they bring to us.
Well, that's interesting that you talk about, recognizing your own bias, because that's been, a really big problem with providers and, even nurses,
Yes.
not just providers, but anyone in the healthcare field, is that you don't recognize your biases. And so you think you're treating everybody the same, but in reality, you really aren't, because you haven't recognized that that's a bias for you and brought it to the forefront like you have, and said, hey, okay, check it at the door. So congrats to you, Renee. That's great.
Thanks. It's been a process. It's always a work in progress. You know that, Kathy.
I know, right? By the time we get it right, it's going to be time to run out.
Exactly.
So I feel so much better about pregnant women having babies in COVID after talking with you. I honestly do. I was just so afraid for them, and my heart just went out to them. And the separation, the fear of separation from your baby after you have it, that just, I cried when I read that. I literally cried because I remember, 30 years ago, right? How I felt as a new mom. And when I read that, I thought, that would just be devastating, just devastating.
Yep. Yeah, I can't even imagine it. I know that it's still happening, and there's a reason. There's part of you that has reason. This is good. This is going to be good for me. It's going to be good for my baby. To be separated, for my baby boy or girl to be healthy. But at the same time, part of you says, "Oh my gosh, everything goes through your mind." If you don't have a built-in caregiver, as most of us, well, I can't speak for anyone else, but I probably could have found someone to take care of a baby if I had to at short notice. But then as mothers, we are looking to nurture everybody, right? And nurturing nurturing men can be amazing too. So, but we're looking to look over everybody. So if I called on my parents and my dad is ill, how is that going to help anybody? So maybe my mom takes care of my child, but then exposes my dad, right? So there's all of this, decision making, and we as OBGYNs and midwives and everybody else have done our best. And I'm sure the conversation we're having, my colleagues are having with their cohorts all across this country and this world, is that I have been through the tease out of, should we have this family member come? And, whooping cough feels easy compared to this. Just get the pertussis booster and move on. Literally, this is like, well, how old is he? Oh, he just got diagnosed with cancer. Well, what would you do? And that is a relationship that I value. I was just telling my sister about this, that I really see my relationship as probably all of you do as well, as a partnership with my patients. So I take these steps with them. If they have questions and they're not getting their questions answered, then I'm there to say, okay, let's talk about it some more. And so I've had, 10-minute conversations with patients every visit. Well, what about this? What about that? What if I need a C-section? I'm going to stay a day longer. Am I going to get COVID? That kind of thing.
Yeah. Yeah.
Speaking of
something
regarding
earlier,
just catching COVID in the hospital setting, are there any procedures that you're not doing at the moment, just for safety measures?
So thank you for the question, April. We started not doing circumcisions for a short period of time. We haven't reinstituted that. Remember, it's an elective cosmetic procedure, but babies really can't, it can only have local for a short period of time, until I want to say 3 months is what my pediatric urologist colleague said. So maybe it's a little bit longer than that, but that's one of the things that we haven't been doing. We still are placing IUDs, thank God, because we need them. And my fertility colleagues did suspend in vitro embryo transfers for a period of time, and they're kind of, I think they're doing the same thing that we are talking about on this call, looking at local data, trying to let that inform what they do. I just got a question on one of my Facebook groups with a mom who said, I was told to delay, should I? And I said, yes. 1 month really doesn't make a difference with the embryo transfer. But I don't know that, if you delay it a year and you're a year older and you're going from 41 to 42, that's a big difference health-wise. And I'm speaking as someone who is almost 50. So trust me, I know. And I had a baby 5.5 years ago. So I get it. I get that, it's hard to make those kinds of decisions when you're an older mom. But those are the kinds of things. So we're still doing IUDs. We're still doing that implant in the arm. We're still seeing patients, and we're just trying to limit the traffic as much as possible. and of course, masks.
Do you think that there'll be backlash? Isn't really the right word, because I've been hearing this from other in other aspects about people that are delaying care because of COVID.
Right.
And you had said earlier, along with some elective procedures, that you know, we're keeping up with the OB patients, but on the GYN side, do you see, I guess, maybe some bad outcomes or bad things because things are maybe just people are putting off, oh, I'm not going to worry about this symptom, I don't need to get it checked out, we're in the midst of COVID, that 3 months from now may end up being a bad decision?
Right. That's an excellent question. I haven't seen that. The scenario I could give you is, you know, I'm having, you know, postmenopausal bleeding, and I had, you know, a family member with endometrial cancer. I'm going to get it checked out, you know, in 3 months or 6 months, and that becomes a year. And, you know, endometrial cancer is highly curable. So that would be a significant tragedy. You know, most of what I see is on the benign side. And I haven't had a lot of concerns on that side. You know, I wouldn't say I was, you know, passing out contraceptive like it's, you know, candy, but, you know, I really believe in contraception. So if someone, you know, needs a refill and she can't come into the office right now, that's a no-brainer for me. So those are the kinds of things that I'm seeing. My colleagues who are urogynecologists, whose patients had to have surgery during that time, where we were shut down for elective procedures, had a lot of complaints from patients. And, you know, they really felt like their bladder saving surgery, you know, really was an emergency. And we all had to kind of, you know, check our feelings at the door. So I'm not talking about keeping the lights on, which is what a lot of my private practice colleagues had to be worried about, right? They had to keep the lights on. They had to worry about paying their staff, who couldn't go without a paycheck, right? They had to worry about lots of, you know, the lack of traffic being a long-term problem. And so I'm lucky enough that we didn't have to worry about any of those things, but, you know, we also don't want to lose patients that we had a really, really good relationship with. Our stoppage was so short that I think that we've been able to recover some things. And while there are some terrible people out there who like cuss out the grocery store clerks and stuff like that, most of my experience has been really, really positive. Like, patients being very understanding. Okay, you know, I know it's going to take a while, but can we set up this procedure? We're feeling a little more pressed because we're close to school. I've always tried to be sensitive to my teachers, so that we can get, and my students, because I take care of younger women as well, so we can get people taken care of before they go off to college or before teachers start back to school. But honestly, Barb, I think that I'll be shocked if I'm in Columbia County, if we open back up. I know that they're saying we're going to do it and it's 2 weeks away, but I think it's a really bad idea. So
I personally think they're going to cave to the neighboring county, who just said they're going to delay till after Labor Day.
Right.
So,
that's what I think so too.
We'll see. That was the hot topic in our clinic this afternoon. What will Columbia County do?
Yeah. So you know.
They kind of lead the state in a lot of things, but they may not lead it in this one.
Right. Exactly.
Oh, goodness. Oh, well, it has certainly, you know, time flies when you're having fun.
That's so true.
Thank you so much again, Renee, for joining us tonight. It's been an extreme pleasure. And thank you again to Barb and April for joining me tonight. And all of you out there, don't forget about the conference. Disorders, time. We have great speakers. So go to the website, check out who all the speakers are, and you can go to rnsnurse.org/conference and find out more information and get yourself registered. So in the meantime, until next week, everyone, stay safe, stay well, and have a great week.
Bye.